Hello. Macular holes are a commonly encountered cause of visual impairment. Over the next few minutes, we'll be discussing some updates in the diagnosis and classification of macular holes. A macular hole is a retinal break located in the fovea. Usually idiopathic in etiology, macular holes can sometimes be associated with extreme myopia, intraocular inflammation, and ocular trauma. Macular holes are believed to be caused by retinal traction, whether this be horizontal, antero-posterior, or a combination of both. Macular holes are clinically identified using slit lamp biomicroscopy. Optical coherence tomography is the diagnostic procedure of choice, while fluorescein angiography has little to or no diagnostic value. The GAS classification is the most commonly used staging system. GAS Stage 1, or impending macular hole, is characterized by loss of foveal contour, visible as a yellow spot, or foveal detachment, visible as a yellow ring on slit lamp biomicroscopy. Stage 2 is now a full-thickness, small, eccentric break and may assume a salami or the classic pepperoni appearance on biomicroscopy. For these stage 2 eyes, OCT reveals partial attachment of the vitreous to the edge of a full-thickness hole. Once eye enters stage 2, the macular hole almost always progresses to stage 3. And in stage 3, the fundus may develop a macular gray cuff of submacular fluid. Stage 3 holes are often associated with partial posterior vitreous detachment with or without an operculum. And at this point, patients often are symptomatic. The next stage is stage 4, which occurs when the posterior vitreous has totally separated from the retina. A Weiss ring may also be seen in these cases. Now let's move on to another classification system. In 2013, the International Vitreous Traction Study Group introduced an anatomic classification system based on optical coherence tomography. So in this structural system, we take into account the characteristics of retinal adhesion, retinal traction, and hole formation. The system provides standardized descriptive groupings which may be used for prognostication of an eye and can be used to guide treatment decision making. The earliest stage in vitreomacular adhesion is characterized by perifoveal vitreous separation with remaining vitreomacular attachment to a fovea that has normal morphologic findings. These changes are brought about by the normal aging changes of the vitreous gel. In general, for eyes with vitreomacular adhesion, the patients are asymptomatic with good vision and only observation is needed at this stage. The next stage is vitreomacular traction, or VMT. And this is characterized by abnormal posterior vitreous detachment accompanied by anatomic distortion of the fovea. Specific findings may include pseudocysts, macular edema, cystoid macular edema, macular schisis, and subretinal fluid. VMT can be subclassified according to the diameter of the vitreous attachment to the macular surface as measured by the OCT instrument. Attachments of less than 1,500 micrometers is defined as focal attachment, while larger attachments are defined as broad attachments. Treatment may be indicated in these eyes when the patient is symptomatic, complaining of distorted vision, or when the patients have decreased visual acuity. The last stage is full-thickness macular hole, which is defined as a defect in all the retinal layers starting from the internal limiting membrane down to the retinal pigment epithelium. Full-thickness macular holes is considered primary if it's caused by vitreous traction, or secondary if it results from other pathology. Full-thickness macular holes may be further subclassified according to the diameter of the hole as determined by OCT imaging. It also can be classified according to the presence or absence of BMT. In the next module, my friend and innovative colleague, Dr. Manish Nagpal from India, will talk about the rationale for the different types of surgical maneuvers performed during macular hole surgery.